I have a pleasure to introduce the next speaker, FIFA Rahman. She is a master in health law from Sydney University and PhD in international trade and intellectual property law from Leeds University. And she is also the UnitAids board member representing NGO, non-governmental organizations constituency. The topic is on access to HIV medicines and diagnostics, but you better introduce your topic yourself. FIFA, the floor is yours, please.
Thank you so much, Andre. And yes, I'll be speaking about lessons from COVID-19 in terms of intellectual property and what we can learn from HIV. So hopefully my slides will be up soon. And we'll start really with how a few lessons, and by no means is this an exclusive list, but basically, next slide, please. Yeah, the first is that what we're seeing from the response is what Vladimir said earlier, which is speed trumps perfection, and the greatest error is not to move. It is true that we don't have complete evidence, but we're seeing that countries that react quickly above everything are doing much better than the countries who are waiting for absolute perfection. And as we can see, there are a number of countries in the West who have done this, and not necessarily waiting for perfection, but simply thinking that this is maybe a disease of the East and being complacent in certain areas. And I want to quote the example of Malaysia. Now, this is not an intellectual property example yet, but there are lessons for intellectual property. An example of Malaysia where so far there have been only 105 deaths. So that's been updated in these couple of days since I've prepared the slide. There have been only 105 deaths. It's close in proximity to China. It receives a lot of Chinese tourism. It acted very quickly to build surge capacity. This phrase that Vladimir also mentioned started building hospitals and renovating hospitals in February to increase ICU capacity, and started procuring diagnostics reagents in February itself. It also diversified its reliance on diagnostics and conducted contact tracing from the start. So there's a sense of urgency that we need to implement, not just in the health system's response, but also in intellectual property, which I'll raise again later. What we've also seen in terms of the second lesson in COVID-19 is that we've seen more examples of pharmaceutical profiteering. And this doesn't end just because it's in a global emergency. And the two examples that I want to give is remdesivir, where there's still very little evidence of treatment efficacy, but we've already seen via leaked stakeholder or shareholder documents that Gilead is already making sales on. And of course, when I talk about the fact that there's very little evidence so far, there's been one trial which shows no improved treatment outcomes, and there have been basically a bunch of different articles. So we don't know whether it's efficacious at all, but there's already money being made from it. The second example that I want to give is, of course, the gene expert machines and the cartridges. There is a campaign going on to reduce the prices to $5, but the situation is that these cartridges and these machines, which can be used for both HIV and TB and sexually transmitted infections and COVID-19, are approximately $20 per cartridge, and most countries can't afford this. So what do we do in the face of pharmaceutical industry profiteering? The numerous intellectual property provisions that can be used to overcome these. And the third lesson is that budgets are shifting, and Vladimir already mentioned this, and we need to be able to anticipate stockouts for HIV, and not just for HIV drugs, but also for TB drugs, as the largest killer of people living with HIV worldwide. And there's, the situation is changing. There's so much news coming out, so we need to really wait and see what's going to happen. But already there are rumored shifts in production in Indian companies. There are rumored active ingredient supply issues from China. So this is something that all of us as people working in the HIV and global health space have to keep an eye on. And the fourth one is central to my presentation today, that there's an increased global consensus on intellectual property solutions to increase access to medicines. And you can see this yesterday from the Pledge conference that was hosted by the European Commission, and President Macron was there, the Prince of Monaco was there, and everybody was saying sort of, you could really sense the sea change around intellectual property for medicines. And I'll talk more about this later, but Merkel said that we need all these medicines and diagnostics to be global public goods. What does that mean? Nobody knows at this stage, but I'll talk about it more in a little bit. Next slide, please. So what can we learn from intellectual property in terms of COVID? What we already saw is that AbbVie dropped its patent rights for Kaletra, but it didn't do this out of sort of the natural goodness of its heart, What you could see, and this is an article from the Financial Times, that Israel moved to issue a compulsory license because Kaletra, or lopinavir-ritonavir, was being used in the treatment of COVID. And it's only when or after Israel moved to issue that compulsory license that AbbVie dropped the patent rights. And we see many examples of where threats to issue compulsory licenses will precipitate a reaction from the pharmaceutical company itself. And we've also seen this in Malaysia, where the rumors and the cabinet decision had been made to issue a compulsory license or government use license for sofosbuvir. And what happened was, when the rumors went out, Gilead issued a voluntary license. So threats in this area are very effective in ensuring that drug prices go down and everyone gets generics. And I know this is very relevant for the dolutegravir discussion in Eastern Europe and Central Asia. The next thing I want to talk about is the Costa Rica proposal. So what is the Costa Rica proposal? It was a letter to Dr. Tedros of the WHO from the president or prime minister, I think it's the president of Costa Rica, saying that we needed a shared voluntary emergency technology pool for COVID technologies. And what does this mean? How does it work? I don't think that anybody sorted out the details yet. How are companies going to voluntarily put their rights in this pool and share it on a sort of open platform kind of basis? Do we know how that's going to happen? Not yet. But there's already a lot of political buy-in, as we saw from the pledge and Merkel saying that these need to be global public goods. There's a real sea change of how people are thinking about pharmaceutical profits. And there's a way to leverage on this for other diseases as well. Next slide. So what's UnitAids role, and what does the UnitAid NGO delegation, which I lead, how does the NGO delegation support UnitAid's objectives? And of course, in the pledging conference, you saw that the chair of UnitAid, Marisol Touraine, was speaking, and UnitAid has, of course, officially, and that's another article from the Financial Times, officially supported the Costa Rica proposal and has a number of proposals internally that they are considering to work on a shared technology pool so that we can get access to COVID technologies. But what are the lessons for HIV, and what is UnitAid doing to deal with the HIV projects that it already has? So for COVID, what are the implications, basically, right? So UnitAid has a number of HIV projects, and what you're seeing now is that there's reprogramming of existing grants. So I'll give you two examples, although this is happening in a number of grants in UnitAid's portfolio. The first one is with the International Treatment Preparedness Coalition, where they said ITPC can use existing funding for access work on COVID. And there's also a project with KNCV, which is a project on TB adherence technologies. And there's already an exploration on how to use existing programming to use the TB adherence technologies to also work in COVID and trace people and make sure that people are getting both TB and COVID diagnostics. But this raises an important question. If there's a lot of reprioritization for COVID, what's the opportunity cost to HIV? And what's the opportunity cost to TB, which once again is the largest killer of people living with HIV? So there's a question about that. And UnitAid also is involved in the accelerator or the ACT in COVID-19, which is supposed to accelerate diagnostics and therapeutics. And UnitAid is officially supporting the Therapeutics and Diagnostics Partnership. But these are very early days. We don't know what the IP implications of these things are. Of course, there's a lot of political buy-in into some sense of a shared technology pool, but do we know what it looks like yet? We don't. And how do we support this? We support this when NGOs from all over the world come together and give myself and my colleague Rohit Malpani, who's an alternate board member, information about what's happening in their countries. So what we're doing right now is monitoring supply issues, for example, because countries are diverting money to COVID. We want to see whether there are stockouts of Kaletra, of dolutegravir, of raltegravir, of all these medications that are used in country. So we'd really appreciate hearing from NGOs on supply issues. And of course, there are a number of projects that are coming up at UnitAid that could require NGO input that could have global impact. Next slide, please. So what are the lessons? I've mentioned them several times already, and this is really in summary, to summarize my entire presentation, that threats to issue compulsory licenses really can result in companies dropping the patents or issuing voluntary licenses. And I gave the example of Kaletra and the example of sofosbuvir in Hep C, but that we know that there are movements in Eastern Europe and Central Asia to do this for dolutegravir, and given the political sea change in attitudes towards TRIPS flexibilities and access to affordable drugs, this might be just the opportune time to get these compulsory licenses and access to generics through the door. The negative point, so I know that Tanya mentioned what positive points we can learn, but it's also important to highlight that we could be facing some negative points, which are supply issues are likely to occur. And we've heard at least rumors that in Ukraine, for example, there are going to be delays. So there needs to be a strategic effort by NGOs to plot and anticipate supply issues and to act quickly. As mentioned in the start, that speed trumps perfection, but also to optimize existing resources, including gene expert platforms, and work on pricing reductions as the global campaign is going. Everybody wants a $5 cartridge for Cephei gene expert products, but also to diversify supply. The countries like Malaysia did well because they procured from a number of different countries in terms of COVID. So we need to ensure that there's a diversification of supply of medicines and diagnostics in HIV as well. And generics is, I'm running out of time, so the generics is an obvious point, I think. And I've mentioned the compulsory licensing for dolutegravir, but also raltegravir. I'm not sure how prevalent it is used in Eastern Europe and Central Asia, but it's very expensive in Southeast Asia, and there's value of going for generics as well if they're available. I am out of time. I hope you enjoyed the talk, and I look forward to listening to your questions and answering them. Thanks very much.